This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 912, recorded on June 23rd, 2022. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
Speaking of viruses, Daniel, we have SARS-CoV-2, we have monkeypox, and now they find poliovirus in the sewers in the UK.
I heard about that. Yeah, that is, yes.
It's vaccine-derived poliovirus, which is interesting because they don't use OPV any longer in the UK, so it must have been imported from another country. And apparently it's doing some local transmission because, that's what would get it in the sewer, not just one person. So
Yeah.
interesting. Yeah. Viruses in the news, right?
Yes, yeah. People, who would have thought you needed to know about viruses? Okay.
Exactly right.
All right. So I realize I always start with, well, we got a lot to cover today. People are like, he always has a lot to cover today. But we have a lot to cover today, as always. And I will start with my quotation. When men are most sure and arrogant, they are commonly most mistaken, giving views to passion without that proper deliberation which alone can secure them from the grossest absurdities. And maybe as we go forward, people will figure out why that quotation came to mind. But let's start with an update. Where are we? And I think it's been a little while since I shared the numbers. And I know everyone has decided, the pandemic is over. But I just want to point this out. As we all decide this pandemic is over and Omicron is just a mild upper respiratory virus, we are still seeing about 2,000 deaths a week here in the U.S. That adds up to over 100,000 people a year dying of COVID, despite vaccines, effective therapeutics, and great access to testing. So keep that in mind. I mean, I know everyone wants to move on, and this is human nature, but just we can keep in mind what's still going on. So one of the things I will start about, right? I mean, how can we keep having all these infections? Hasn't everyone been infected? Aren't we running out of people? Isn't that part of those equations? Well, the article Outcomes of SARS-CoV-2 Reinfection was posted as a preprint. It's currently under review. And this is coming from the U.S. Department of Veterans Affairs again. So they built this cohort of people where they looked at those with just a first infection, and that's 257,427. And then they're going to compare those in this database to those who have had reinfections. And so 2 or more infections, and then they're going to have a non-infected control group. And then here's really this question is, what sort of outcomes are we concerned about? Because there is this idea, I think a lot of people have it, that if I survived my first infection, that I'm really going to be just fine this second time. There really shouldn't be any problem. Reinfections, the popular wisdom, right, is that reinfections are mild, nothing to worry about, nothing to see here. Well, here's the data, and I'm going to go through some of this, and I'm going to put a link in our show notes. But compared to first infections, those with reinfection exhibited an increased risk of death, all-cause mortality, and that hazard ratio was greater than 2. Increased risk of ending up in the hospital, that was threefold, people getting 2 infections versus 1. Pulmonary issues, and these are all hazard ratios, 2.5. Cardiovascular issues, 2.4. Coagulation, hematological disorders, over 2. Fatigue, over 2. GI issues, 1.7. Kidney disorders, mental health, diabetes, musculoskeletal, neurological disorders, all elevated. So I just want to point out this popular wisdom, so to speak, that if you did okay the first time, that all's going to be good going into the future, is not really being borne out when we're following the numbers.
Daniel, is this depend on vaccination, not vaccination, or they don't know in these people?
Yeah, I would hope, and actually this is why we continue to recommend that people get vaccinated, that vaccination would reduce these risks, and it certainly does.
What do you think of the the underlying mechanisms for why second and so forth infections cause these issues. Do you have any thoughts?
Yeah, I mean, it is tough because one of the things we do point out, right, is the first time around, right, we lost 1 million of the most vulnerable Americans. Um, but every time you get an infection, different variants, you've now survived. So there's been you're now a bit older. Maybe you developed other health problems, and we certainly see that. So maybe you went into the first infection. Now you're going into the second infection. You have a new diagnosis of diabetes. You have some residual pulmonary issues. I actually just recently had a gentleman who it was about a month prior. He had his first infection. He did fine. He survived it in the outpatient setting. About 30 days later, we had this whole discussion. He was testing positive again. Is it really, lingering, residual RNA? We did a quantitative PCR. It was in the 20s. He actually progressed to become hypoxic this second time. So I'm not sure I have all the answers, but we're certainly seeing this disturbing situation. All right, children.
I'm sorry, one more thing.
Yeah.
Do you see this with influenza or any other respiratory infections?
It's really interesting, and it may have to do with the fact that we have so many circulating variants. So early on, right, in the COVID pandemic, people would get COVID, 3 months would go by. We really were sort of protected citizen for that period of time. But now we're seeing actually some pretty frequent reinfections. As early I was describing a month there, 1 or 2 months. And as we're describing here, people with 4 infections in just this 2-year period. We didn't really see much of that. We don't really see much of that with the flu. Usually you get your 1 influenza year. We certainly see some reinfections, but it tends to be less common. All right. Children. And this has changed. I will say children are at risk of COVID. I think I've been saying that for a long time now. And I want people to remember back in the early days when everyone was fighting to be first in line to get vaccinated. Everyone was trying to claim their job was essential. We had the unions pressuring the politicians. We had some large healthcare systems, that shall not be named, where they were sneaking shots to the ex-wives of administrators and risking, financial penalties. Well, nowadays it looks like just about anybody who wants to can get vaccinated, even the littlest children. But first, I want to give some perspective. And this is really the David Hume quote at the top. Don't just throw out, your thought, your blanket thought on vaccinating children. Let's talk a little bit about when I say children are at risk from COVID, what are we talking about? So as of June 9th, 2022, we have had over 43,000 children hospitalized and over 1,000 children have died from COVID. It's not just the flu. That is an extraordinary number. For the less compassionate out there, because I know what everyone thinks, 1/3 of all these kids hospitalized appeared completely healthy prior to being hospitalized with COVID-19. For all the age groups under 18, COVID is one of the top 4 or 5 causes of death for this last year. Now, with SARS-CoV-2 virus here to stay, the choice is either to protect our children or let them get infected without this protection and let them have that risk of death, hospitalization, or long-term impacts of COVID. We also have all the horrible social and mental health impacts that are much harder to quantify. But I want to put this so we think about death. We think about hospitalization, but one of the other things that is really out there as I'll say a specter is long COVID. Do kids get long COVID? And I want to bring all this up before we mention where we are with vaccines. So this was a last minute add-on article, long COVID symptoms in SARS-CoV-2, positive children aged 0 to 14 years and matched controls in Denmark. Long COVID kids decay. And this is a national cross-sectional study that was just published in the Lancet Child and Adolescent Health. So these are the results of a nationwide cross-sectional study that included children with a confirmed SARS-CoV-2 positive PCR tests. These are the cases. And then we have matched controls from Danish national registers. Previously, 4 weeks has been used as the definition of long COVID. This is an update. People are not following this. As of October 2021, a new case definition from the WHO defines long COVID to be symptoms lasting 8 weeks or longer, right? So this is a more rigorous. And actually, I agree with this. 4 weeks is soft, 8 weeks, that's a long time to still be having issues. And that's what they're using this study. So there were 38,152 in the case group of this study compared to 147,212 in the control group. So what they're trying to do here is subtract out the background. So they saw long COVID across all age groups. So let me just go through each age group with the percent estimated to have long COVID once they did the background subtraction. So 0 to 3 years age group, right? This is that under 4 that we're going to mention are now going to be eligible for vaccination. 8 weeks out, 13% still had symptoms. 4 to 11, 4.4%, 12 to 14, 4.7. I'm actually going to click on my link here because I wanted to go to figure 2 to actually just talk a little bit about the actual, what are these symptoms? And I think this is really important. So we're going to have a link to this in our show notes, and I'm going to encourage everyone to go to figure 2 of this publication. So let's first look at those youngest of these children. So the youngest children, and this is that 0 to 3 years. This is where we're seeing stomach aches, we're seeing fatigue, we're seeing pain in the joints, we're seeing mood swings, we're seeing fevers, we're seeing ongoing cough. And then as we move forward, we actually get into our more typical symptoms that we're used to seeing. So I'm going to encourage everyone to look at this. These are young children under 4, 13% of them were still having issues. And if you look at the ones that separate, these are kids who are continuing at 8 weeks still to have a cough, still to have fever, still to have a lot of these issues.
I presume these are all unvaccinated kids, Daniel?
Unfortunately, the situation, particularly in the youngest, is going to be unvaccinated. So this is my, my sort of using emotion to hopefully sway people. And I do. I have compassion for adults with long COVID, and I definitely take care of a lot of individuals. But periodically, as I've shared, I've been asked to help with children and adolescents who continue to suffer with long COVID. And I'm sure I've shared the story of that teenage girl whose mother showed me videos of her dancing, who now has the intractable vomiting triggered by just having her sit up for more than 45 minutes. So with that as background, why am I so excited that we're going to have access to vaccines for the youngest children? On June 18th, we heard the CDC recommends COVID-19 vaccines for young children. The CDC director endorsed the Advisory Committee on Immunization Practices, recommending all children 6 months through 5 years of age, adding this, should receive a COVID-19 vaccine. So this eligibility expands access to vaccination to nearly 20 million additional children and means that all Americans aged 6 months and older are now eligible for vaccination. And with our encouraging of women to be vaccinated, I'll say pregnant individuals to be vaccinated during their pregnancy or before their pregnancy, we're also hoping that we're going to get that maternal transfer of protection even to those under 6 months of age.
So, Daniel, how does this information that you just gave us, how does this jive with the Surgeon General of Florida, who said there is 0 risk in children for COVID? This is a physician, I understand. How can a physician say that?
Yeah. I unfortunately, Vincent, and I think everyone is aware, is people are willing to say things that are their own personal, financial, and political best interest, as opposed to feeling like they need to respect the truth. I mean, and that's why I started off with this, ahead of time. Over 1,000 children have died. That's a risk. I don't know how that can be interpreted anyway. Over 40,000 children have ended up in the hospital. They want to believe it's fake news. They don't want to believe what the truth is. There's a special place in a fiery afterlife for such individuals. All right. But what about, and I sort of alluded to this a little bit, what about if a mother gets COVID-19 while she's pregnant and is unvaccinated, right? Because we've been really pointing out that pregnant women enter a period where they are actually at about 20 times the risk of bad outcomes compared to women that are not pregnant at about the same age. So, what about their children? How do the children do when we look at them about a year out? So, the paper Neurodevelopmental Outcomes at 1 year in infants of mothers who tested positive for SARS-CoV-2 during pregnancy. This was published in JAMA Network Open. And these are the results of a cohort study of 7,772 infants delivered during the COVID-19 pandemic. In this cohort, 222 of the mothers had a positive SARS-CoV-2 polymerase chain reaction test during the pregnancy. So, maternal SARS-CoV-2 positivity during pregnancy was associated with a greater rate of neurodevelopmental diagnoses. This was over a twofold increased odds ratio. So, there was an interesting comment by the authors, and I'll just read it. We observed neurodevelopmental diagnosis to be significantly more common among exposed offspring, particularly those exposed to third trimester maternal infection. And the majority of these diagnoses reflected developmental disorders of motor function or speech and language. So I was actually surprised that it was a third trimester. But this really builds on other studies, really reinforces our recommendation that women should not wait until after that pregnancy. They should get vaccinated before, during. Really, if you're giving advice to pregnant women, if you're suggesting they delay that vaccination, that's bad advice for the mother. That's bad advice for the child. We are now where I like to say use tests intelligently. And remember, there's more out there than just COVID. So when someone comes in, think about COVID, think about influenza, think about RSV. And remember that incubation period is still 2 to 14 days. Most people are going to show up in that first week, but we still have people that turn positive out to day 14. All right. So active vaccination. I really feel, and I'm going to be positive here, that we are getting to a new stage with regard to COVID-19 for everyone here in the United States. The last few segments of our society that have been left out were the youngest individuals. We now have vaccine access for them. But what about those immunocompromised, those with transplants? So the article evaluating clinical effectiveness of SARS-CoV-2 vaccine in solid organ transplant recipients is a propensity score matched analysis published in Transplant Infectious Disease. So here's really looking at that question of how effective are vaccines in these folks who got solid organ transplants. So these are the results of a retrospective cohort study where they're looking at the SARS-CoV-2 infection rates between those folks that have received 2 doses of mRNA or 1 dose of the J&J vaccine, and those that are not fully vaccinated. So those partially vaccinated, those are unvaccinated. I do want to point out here that this is 2 doses, and we're now up to recommending 4 doses in these individuals of the mRNA vaccines, and we're really not doing much of the J&J. So sort of keep that in mind. And I'm just going to hit on what were the high points that they saw. All the COVID-19 related deaths in this study were in unvaccinated patients. No deaths in the vaccinated patients. Some hospitalizations may have been prevented with the use of monoclonal antibodies in the outpatient setting. 3 patients in the fully vaccinated, 9 in the not fully vaccinated group received monoclonal antibodies, avoided hospitalization. So it could have been worse. Our transplant colleagues really seem to love those monoclonals. And I understand why. There's a lot of drug-drug potential interactions that we can have with PAXLOVID. Very limited access to remdesivir. So it's really a population that is still getting a lot of monoclonal antibody therapy. And just a bit from the conclusion, I like to keep reinforcing this with regard to measuring the humoral immune response to COVID-19 vaccination and infection. A reminder, validated cutoffs for many of the wide array of available antibody assays still being investigated, making it difficult to interpret the meaning of a given antibody test. Our results would show protection from infection, severe critical disease, hospitalization, and death among fully vaccinated solid organ transplant recipients, suggest that measurement of antibodies should not be the sole surrogate marker for vaccine effectiveness.
Gee, who's been saying that for 2 years now?
I hate to say it is painful, but at some of the cancer centers of excellence throughout this country, we still have people, I don't know, making believe they're immunologists and not giving patients the protection they need based on some antibody test that they, okay. And remember, this is that same population where we're discussing Evusheld, giving that passive antibodies to people who are concerned may not be able to produce those effective neutralizing antibodies. All right, the article. We're back to Syrian hamsters. I know that that's a favorite of Vincent. I'm sure Vincent has a pet Syrian hamster. Therapeutic efficacy of monoclonal antibodies and antivirals using against SARS-CoV-2 Omicron BA1 in Syrian hamsters, published in Nature Microbiology. A note for authors of these types of papers, you need something right up front to keep track of what monoclonal antibodies you're talking about. This is like War and Peace. I'm like let me take their conclusion. Of the FDA-approved therapeutic monoclonal antibodies, that is REGN 10987/REGN 10933, comma, COV2-2196/COV2-2130 and S309. I don't think people know what you're talking about. So let me translate this. So they're looking at the Regeneron cocktail. They're looking at Evusheld, and they're looking at S309, an antibody made by Abcam that's supposed to be variant resistant. So they only found that Evusheld efficiently inhibited BA1 replication in the lungs of hamsters. So my translation, I'm just going to say that one more time. They tested the Regeneron cocktail, some variant resistant, supposedly variant resistant monoclonal from Abcam, and Evusheld, and found in this animal molecule that Evusheld and only Evusheld worked on the monoclonals they tested. I would have liked if they had tested bebtelovimab, but we didn't quite get that. All right, and now we are cutting to the time when a person has detectable virus, when a person develops symptoms, when a person first develops COVID-19. And I'm actually going to share a little bit of a story, and I want everyone to think, what would you, as a TWiV listener, have done in this situation? So this is a gentleman, ends up in an emergency room having chest pain, known history of coronary artery disease, so blockages of the blood vessels supplying the heart muscle. In the emergency room, they're evaluated. They are allowed to be discharged. They are seen by their cardiologist, risk stratification, other things. But period of time later, they end up admitted to the hospital with an acute cardiac event. They spend a period of time in the hospital. They're getting ready to leave, but now they start to develop some mild upper respiratory symptoms. They are found to be COVID-19 positive. What should they do in this high-risk elderly individual who just suffered an acute coronary event? So we're going to go through our options, and then I'm going to tell you what happened. So number one, this person is in the hospital, but they are not admitted for moderate to severe or severe to critical COVID-19. So they could have been given PAXLOVID with an 89 to 88% reduction in progression if given in the first 3 to 5 days. But this individual was on statins, a number of other medications. So there may have been a reason to move on to the next in our list. The next would be remdesivir, 3 days. They're already there in the hospital. They could have given that first dose and either kept them for a couple more days or had them come back for a couple more days, about an 87% reduction in progression. And that would have not had the concerns with drug-drug interactions. We still could have done bebtelovimab. And then as sort of a low-hanging fruit, molnupiravir. So let's go through our list and let's find out what happened to this individual. So I'm going to start with the preprint to now published article in the wink of an eye. I didn't know you could get things published this quickly, but I am impressed. Remember that article we discussed as a preprint, rebound phenomenon after nirmatrelvir-ritonavir treatment of coronavirus disease 2019 in high-risk persons? It is now published in Clinical Infectious Disease. And just to basically remind people who may or may not have listened last time, in this cohort, 93% fully vaccinated, treated with PAXLOVID for COVID. Only 2 patients, 0.4%, required hospitalization by day 30. And these were for reasons unrelated to the rebound. 0 deaths in this high-risk cohort that were treated with PAXLOVID. Only 4. Imagine that, only 4. Not every single physician I know who wants to be in the New York Times. Only 4 patients, less than 1%, experienced rebound of symptoms, which were generally mild at a median of 9 days after treatment, and all resolved without additional COVID-19 directed therapy. They actually have a really nice description. You can look at each of the 4 rebounders because everyone has their theory. And I'm going to point this out. 2 of them were started on therapy on day 1. The other half, the other 2, were started on day 3. No obvious pattern there. I do worry that there's this perception or confirmation bias out there. Everyone is looking to have this experience. I was talking with my friend Stefan Mulbauer, the head of the ER at one of our local hospitals, about this. And it really is one of these things. Everyone is convinced that COVID is a 5-day illness. And when they have any symptoms during that second week, if they took PAXLOVID, they're quite upset about it. So just want to point that out. This is what I think is a really critical article. And boy, I think I've actually mentioned this article about 10 times just today. And this is an MMWR early release, hospitalization and emergency department encounters for COVID-19 after PAXLOVID treatment, California, December 2021 to May 2022. So this just reinforces, as we've been saying, what PAXLOVID actually does. We have no compelling data on PAXLOVID making you feel better much more quickly, shortening your period of infectiousness, or preventing long COVID. But we do have compelling evidence in people at high risk that this reduces their chance of hospitalization or death. So in this report, COVID-19 related hospital admissions and emergency department encounters occurring 5 to 15 days after PAXLOVID treatment were described using data from a large integrated healthcare system. That's the California Kaiser Permanente, Southern California. Reports of such hospitalization or ED encounters occurred infrequently, representing less than 1% of PAXLOVID treated patients over the study period. So just reinforcing that when administered at an early stage treatment, PAXLOVID prevents COVID-19 related hospitalizations among persons with mild to moderate COVID who are at risk of progression to severe disease. We mentioned remdesivir with that 87%. We mentioned bebtelovimab and the fact that we do not have great efficacy data there. We're optimistic that it works. We have molnupiravir as number 4. Let's get back to our individual. The decision was made not to give him PAXLOVID. The decision was actually made to give him no therapies. He was discharged from the hospital, readmitted a week later, and a week after that, he died. So as I made a comment to our group this morning, that was a missed opportunity. We had the opportunity to reduce the chance of that outcome by 90%. So let's not be that person. Let's not wait. Let's not say it's mild. Mild means you're in the first week. Severe and critical is what happens that second week if you miss the opportunity. Moving on to the early inflammatory phase. And I continue to reinforce here, once we miss that opportunity in that first week and they end up in the hospital, we have some tools, but limited impact. We have steroids, we have anticoagulation, pulmonary support, maybe remdesivir if we're still early enough, tocilizumab. Really, at this point, we're chipping away those dramatic, powerful tools. We've lost our window. And the tail phase, long COVID, post-COVID, actually hitting this twice because we hit this up front talking about children, but the article Risk of Long COVID Associated with Delta versus Omicron Variants of SARS-CoV-2 was published in The Lancet. Now, these are the results of the case control observational study where the authors set out to identify the relative odds of long COVID defined by the National Institute of Health and Care Excellence Guidelines as having new or ongoing symptoms 4 weeks or more, right? So this is 4 versus the 8 at the WHO. So I want everyone to walk away with the fact that the updated is going to be 8. This is using 4. This is in the UK during the Omicron period compared with the Delta period, right? So if we go out to 8, I am hoping that we're going to see a little bit lower numbers here. So they first identified 56,003 UK adults first testing positive between December 20th and 2021 and March 9, 2022. So these were the Omicron cases. And they're saying that because about 70% of the UK cases at that time were attributable to Omicron. Now, they're going to compare these to 41,361 UK adults testing positive between June 1, 2021 and November 27, 2021. So those will be our Delta cases, where during this period, about 70% were Delta. So we've got these numbers. We've got our most likely Omicron, our most likely Delta. So among the Omicron cases, 41.5% experienced long COVID at this 4-week cutoff. Among the Delta cases, 10.8% experienced long COVID using that 4-week cutoff. So for starters, this is interesting, where although you might see a lower percentage with the different variants, when you get the many, many more cases with Omicron, you actually can end up having more people with long COVID. So a lower percent of a bigger number can actually equal a bigger number. Well, what about vaccination? And Vincent, I pasted in the figure so we can look at it together. And we will have a link so people actually can go to the show notes and be looking at these figures as we talk. So this is the figure. And if the participants had their vaccine more than 3 months before and then got infected with Omicron, 2.8% had symptoms past 4 weeks, compared to people who got Delta less than 3 months post-vaccination, with 8% having symptoms past 4 weeks. So I sort of tried to translate this. The lower incidence of symptoms past 4 weeks was in those less than 60, greater than 6 months past vaccine infected. Omicron, that was about 2% or 1 in 50. And then the highest group was those who were 60 plus, less than 3 months post-vaccine. With Delta, that was 10.4%. So we're seeing this interesting relationship, actually, which I'm hoping we could talk. So we were seeing a little bit of a difference with Delta versus Omicron. We were also seeing, as we got farther out from the vaccine, that there was less likelihood of developing symptoms past 4 weeks, so long COVID. So I don't know if you had any thoughts about the immunology there, Vincent.
Well, that is what stuck out at me, that if you have less than 3 months between vaccination and your infection, you're at higher risk, which is suggesting to me that you need to allow the immune response to mature a bit more before it fully protects you. And that's consistent across the 18 to 59 and the greater than 60-year-olds. So something in common is going there. The other thing that struck me is that for 3 to 6 months vaccine in this over 60 group, the error bars are huge, huge.
They are. They really
are.
I
don't think you can conclude anything from that. There's too much noise. And part of the issue, as you know, Daniel, is how many symptoms does it take to, it just takes one to be defined as long COVID, but some of these people have more and less. And so this is complicated, right? It's not a straightforward analysis. And I don't know if you saw the commentary in Nature this week. The title was something like, "Why does every long COVID study give you a different number?" Right? It can be 15% or 50%. And that's because they're all different. They're all different populations. And they also say, which is really interesting, just because a study has a lot of people in it doesn't mean it's representative.
Yeah. No, I think, and we even touched a little bit, how you define. Is it 4 weeks? Is it 8 weeks? Is it a single symptom? Is it a constellation of symptoms? And then even severity sort of figures into all this. So still a lot to do. But even the most optimistic here we had was people vaccinated 6 months, letting it mature. We still were seeing 2% of people, 1 in 50, still having persistent symptoms 4 weeks afterwards. Maybe if we got to 8 weeks, it'll be a little bit better. But
Daniel, what do you think? I mean, do we have data on the percentage of long COVID that resolves at 4 weeks, 8 weeks, 12 weeks, etc.? What if you waited a year? What would the numbers go to? Would it not change, or would it change?
Yeah. And I mean, it's tough because we have to then do this with variants, with vaccine. We certainly see that numbers go down over time. I mean, this is one of those things where, if you just continue to be supportive,
Yeah.
not be dismissive. A certain percent of your patients are just going to get better over time. We really don't know yet. Is there a percent of patients that just will not recover, even given enough time? I mean, I think we've talked a little bit about other post-infectious or post-viral symptoms like chikungunya, and that's something where we have enough data to know like what percent at 1 year, at 2 year, at 3 years still have that debilitating arthritic pain, for instance. But yeah, we don't have enough time. I don't think we have enough data yet to really know.
I mean, people get very scared of long COVID, but if you see 8%, that could change in 6 months. So don't take these studies as gospel yet.
Yeah. And I think actually, this is a tough issue because a lot of people are making decisions, risk assessments, and this
Yes.
concept that unless my risk is zero, I will stay locked in my home with an N95. And people would like better data on long COVID to help them make decisions. What's my age? What's my vaccination status? What's the circulating variant? What is my actual risk? Can I go out to a restaurant? Can I go to that birthday party? And I think that is still the one thing hanging over us. And by the way, if I get long COVID, can there be some kind of effective treatment? So this I see as being one of those things that's continue to challenge us as we try to move forward. And as I always like to conclude, no one is safe until everyone is safe. There's an entire world out there, and in many areas, we still do not have great access to vaccines or therapeutics. So I want everyone to, I say, pause the recording right here, go to parasiteswithoutborders.com and click the donate button. Even every small amount helps us do the work we're doing. But also, we are continuing our fundraiser for Foundation International Medical Relief of Children. So for the rest of June and all of July, donations made to Parasites Without Borders will be matched and doubled up to a potential donation of $40,000 to our clinic in Bududa, Uganda. I say our clinic, Foundation International Medical Relief of Children. I think of it as our clinic. And really, this clinic is essential. Over 100 children and mothers and fathers are cared for here. It's a malaria endemic. It's a very limited resource area. If FIMR can't do its work, there's over 100 individuals a day at risk of dying, of succumbing to these illnesses.
Time for your questions for Daniel. You can send yours to daniel@microbe.tv. Carolina writes, my uncle Andy, 61, woke up Monday with a sore throat, tested positive for coronavirus. He has an international flight scheduled for Sunday, and he'll be abroad for a long time. Tonight, he's going to receive PAXLOVID, fully vaccinated and in an at-risk age group. His primary concern is infecting others. How should he approach this delicate situation in terms of behavior, and what should the family expect from doctor feedback at this point?
Yeah, I'm doing the math in my head. So, if symptoms started Monday, so that's day 0. So Tuesday, Wednesday, Thursday, Friday, Saturday. So Sunday is when he moves from isolation for the infected to precautions. I'm trying to figure out how this individual can be on an international flight, keep an N95 on the entire time, not infect those people around them. The shortening of the isolation to 5 days, followed by precautions for 5, was really an economic decision. Because people need to deliver food, they need to deliver healthcare, they need to drive the buses. It wasn't so that someone could jump on an international flight. So, yeah, I think you are putting people at risk. I don't understand how you're going to be on an international flight. It's going to come off. You're going to go to the bathroom. You're going to drink something. You're going to eat something. And when you do that, you're going to be spreading virus to those around you. So, yeah, that's the reality. You are infectious in those 6 through 10 days.
It's important that you mentioned earlier on this episode that we don't have any good data about how PAXLOVID affects shedding, right?
We don't. We have no compelling data that, this is not like getting those antibiotics and 48 hours later you can share your toothbrush with your sibling. Not sure you're ever supposed to do that. But no, there's no compelling data that PAXLOVID decreases your contagiousness to others.
Sounds like if he's going to be in Europe a long time, he should just delay his flight for a bit, right?
That would be the responsible recommendation.
Laurie writes, we are a big, busy pediatric office in San Francisco. We're excited to finally offer COVID vaccines to our youngest patients. We're barraged by questions. The most common is by far, how long should we wait after our recent COVID infection to get the vaccine? Of course, everyone has their own story, but barring a compelling reason to vaccinate ASAP, my understanding is that it's best to wait 2 to 3 months after recent disease to vaccinate. The AAP is saying otherwise. Pediatricians across the U.S. await your response with bated breath. We cannot reach a consensus on this one. We will be using Moderna, by the way. I'm curious what local peds are choosing back east.
Yeah. I'm going to do it backwards. So, if you're looking at the two choices, right, Pfizer versus Moderna, I mean, Moderna is sort of the no-brainer because, right, the data was you get that first vaccine, 4 weeks later, you get that second. At 6 weeks, you basically achieve separation of the curves. You're considered protected. You're considered, fully vaccinated. Pfizer really is a 3-shot series. So, first shot in June, second shot in July, and then 5 months later, right? So that's December. It's Christmas time. So I know a lot of our local pediatric practices are looking at Moderna. Now, it's nice to have both options, I'll be honest, because as opposed to, I guess, when I'm not honest, but no, the Pfizer has less reactogenicity. So a pediatrician might want to make that judgment call saying, this is a mom. I see some vaccine hesitancy here. If her child has a fever, which they might, has some reactogenicity, she may just said, I'm throwing in the towel. So it's actually nice to have both options. It is a challenge. I say that because you're then making the judgment call that you can convince this family, this parent, to go ahead with 3 shots versus just 2. The other is, what about this issue? What about waiting? Early on, and I think we sort of, we made this bed and now we're trying not to sleep in it, is early on when we first had limited access to vaccines, there was this whole concept of waiting 3 months before you were vaccinated after an acute infection with the ancestral virus. And you probably could get away with that because we were not seeing a lot of repeat infections. But now it's very clear we're seeing second, third, fourth, fifth infections, some of those infections as little as a month after the first, particularly in children. An Omicron infection, the data would not suggest that you have great protection from that. So really, I am on board, lockstep with the American Academy of Pediatrics. When the child is better, when a couple weeks have gone by, let's get up, let's start that vaccination series.
Lou writes, my mother's 75, high BMI, type 2 diabetes, hypertension, has had 4 shots of Pfizer, last one in February. Next month, she'll be coming to the U.S. to stay with her daughter and grandchildren for 2 months. My question, if she gets COVID, will she be able to have access to PAXLOVID as a foreign visitor? Whom should she turn to? She'll be in the New Canaan, Connecticut area.
Yeah, I don't see there being any issue. Paxlovid is not something that is supplied under your health insurance pharmaceutical benefits. It's here in the U.S., our government has supplied Paxlovid, our tax dollars at work. So I do not see why it would be an issue accessing Paxlovid.
And one more question from Lou. In our circle, we come across a number of people, me included, who had symptoms, but the antigen test did not turn positive till 3 to 4 days later after the worst of symptoms had resolved. In my mother's case, this would be bad to miss the early window of opportunity for antiviral treatment. I thought the only thing we can do is, if symptoms appear, do a daily antigen test, and if negative, do a PCR. Any other advice?
Yeah, no, I think this gets to using your tests intelligently. The antigen tests have a lower sensitivity than the PCR. Unless you're willing to wait. And we've talked about those studies where you do serial ones. Timing does matter. So if there's concerns, and one of the nice things that the antigen tests have done is they've relieved the amount of pressure on our molecular testing. So if you're concerned, go to that urgent care, get that molecular test. If it's positive, then you've also connected with someone who hopefully can get you going on early treatment.
And Cliff writes, I have a question regarding the timing of my grandson's vaccination. During the second trimester of her pregnancy, my daughter got both doses of Moderna, a booster 3 months postpartum. The grandson was born August 2021, being breastfed. In May, the mother had COVID symptoms, had a positive RT-PCR. And during this time, her son, 9 months old, had flu-like symptoms but did not test positive. With the availability of a vaccine for infants, Should the boy receive the first dose now or wait 3 months until after the May episode to have him vaccinated? And this is a similar question
Yeah, no, so
that
this is a
we
similar
answered
question,
before.
and there's to me there's no reason to wait. Go ahead, get that first shot, and if we've actually talked about is that second shot, should it be 4 weeks? If you delay it a little bit, that's fine as well. But I would start on that vaccination series, just really echoing what the American Academy of Pediatrics is recommending.
And he says, how protective is mother's milk compared to vaccination? And will the milk act, will it decrease the effectiveness of the vaccine?
Yeah. So the mother's milk will not decrease the effectiveness of the vaccine. I don't think we have any evidence or even, mechanisms where we would worry about that. And even we've discussed some of the data on giving, passive monoclonal antibodies to people and then vaccinating, really minimal effect there. So I'm not concerned that the breastfeeding is going to have a negative impact on vaccines. The vaccines are more effective than breastfeeding. So do both. Do both.
That's COVID-19 clinical update number 120 with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And everyone be safe out there.